Welcome to 40 Weeks and More. My name is Edem Knight-Tay. Every pregnant woman requires care and attention. That care and attention is heightened if this pregnant woman is a sickle cell disease patient. We are told it requires a multi-disciplinary team approach. Today on 40 Weeks and More, Priscilla will tell us her story, her journey of how she found love, how she got pregnant, went into labor, and had her children with sickle cell disease. Obviously, it came with its own challenges. All of that coming up right here on 40 Weeks and More. Please stay. To our sponsors, Ernest Chemist Limited, Labadi Beach Hotel, and Shape Healthcare Specialist Medical Center. Excellent quality expert care. Thank you so much for your continuous support for 40 Weeks and More. We are eternally grateful. And also to DecoZone, Doberta Merchandise, to Lunch Avenue, and Aruluri. You all have been very supportive and we appreciate you. We are getting into the conversation, and as you know, today we are talking about sickle cell disease and how it impacts pregnancy, all the challenges a sickle cell disease patient goes through during pregnancy, and most importantly for me, the hope that a sickle cell disease patient has. We're going to talk about all of that. But before we get into the conversation, you definitely know that you have to meet my guest, right? So meet my guest.
My name is Priscilla Brookings-Kotey. I'm here to share my story on sickle cell and pregnancy on 40 Weeks and More.
Sickle cell disease, conception and pregnancy on 40 Weeks and More. My name is Dr. Sefogah, consultant obstetrician gynecologist at Shape Healthcare Specialist Medical Center and a senior lecturer at University of Ghana Medical School.
Hi, my name is Dr. Eugenia Vicky Asare. I'm a senior specialist hematologist at the Ghana Institute of Clinical Genetics, Kolebu. And today we'll be talking about sickle cell disease and pregnancy on 40 Weeks and More.
Thank you very much for joining us today on 40 Weeks and More. My guests are seated. Hello, Dr. Eugenia Vicky Asare.
Hello.
You're welcome to 40 Weeks and More.
Thank you.
I'll skip Doc in the middle and say hello to Priscilla.
Hi.
How are you doing today?
I'm good, and you?
You're well. I am well. Thank you for asking. And Dr. Sefogah. Good old.
Yeah.
You're welcome
Presenting.
again.
Thank you very much.
Great. As you're all well aware, today we are talking about sickle cell disease and, you know, everything that comes with it, especially so in pregnancy. But we'll set the tone right. Let me turn to Dr. Asare and find out when we say sickle cell disease. For most of us, we just know that the person is always falling sick, the person is weak, they can't do so much, and that's what we know about sickle cell disease. And also, maybe it's a misconception, you will help us to understand it. We also have heard and know that they usually probably don't live for too long. So break it all down for us. Sickle cell disease, what is it before we get into, you know, having sickle cell and pregnancy?
Okay, thank you. So when we talk about sickle cell disease, it is one of the commonest inherited blood disorders.
Okay.
I say inherited, that means you get it from your parents. It is not contagious.
Okay.
Okay. Now, if we look at the blood, blood is made up of a lot of tiny particles called cells. And these cells, we have the red cells, white cells, and then platelets. They all have a function to play. The red cells contain a red pigment called hemoglobin. And this hemoglobin is responsible for carrying oxygen throughout the body and then delivering the oxygen to the various tissues.
Okay.
Now, for one to get sickle cell disease, you'd have to inherit two abnormal hemoglobins. The normal one is hemoglobin A. So anything apart from A is abnormal.
Okay.
And then you also inherit one S, hemoglobin S. So you'd have one abnormal hemoglobin with hemoglobin S.
Okay.
So that is sickle cell disease. that means that you can have various forms of sickle cell disease.
Okay, let me quickly ask a follow-up question.
Good.
How do you inherit this?
So, just like the way sometimes they tell you look like your parents, okay, it's the same inheritance. So you get one hemoglobin from your father and then one from your mother.
So it means that if your parents have the abnormal cells, you could inherit them.
Yes, if they have the abnormal cells, one of them having the abnormal hemoglobin, which is S,
Okay.
then yes,
You will inherit
you can
the
have
S.
sickle cell disease.
Okay.
You inherit one S from either parent and another abnormal hemoglobin from the other parent, then you would have sickle cell disease.
Okay, meaning that if you have parents who have one parent has AS, the other parent has another AS,
Yes.
you could be inheriting the SS.
Yes.
Another child could be inheriting the AA,
Yes.
and the match goes on.
Yes.
Okay, I am a good student. Doc, your certificate, no?
Yes.
I hope you are making
Photocopy.
photocopies of
Yes,
it.
you are
Okay,
gradually
great.
earning it.
Now that we have a good understanding of what sickle cell disease is, let me turn to Priscilla, who will be sharing her story with us on the show today. Priscilla,
Hi.
so you knew you were a sickle cell disease patient before you got married?
Yes, please.
Okay.
I knew when I was age 5.
Oh, wow. Age 5. But did
Yes.
you understand what it was at age 5?
I didn't understand. So my mom used to take me to the clinic every now and then. So as I grew up, I understood what it was.
Okay, but how are you feeling? Do you faintly remember from age 5 how you were feeling and how, you know, all that was happening to you?
When I was a child, I didn't understand, but now I do.
Okay, but were you falling sick as a child?
Yes, at least once every month I go on admission.
Okay, we hear that sickle cell disease patients go through a lot of pain. Is that true?
Yes, please.
Can you describe some of it?
So the pain is like rheumatism. It's every patient and how the pain it's like. So me, mostly I have it in my joints and sometimes my stomach,
Wow.
depending on how it starts.
And it's excruciating, like
Yeah, it's
pain.
very painful.
Wow. She talks about rheumatism, Dr. Asare. And I thought that was a very normal thing because back then in secondary school, I mean, I remember some of my mates, sometimes they use about 3 bandages, you know, around their knees because the place is cold, they have rheumatism and they're feeling cold. They wear, you know, they can wear about 3 cardigans. And sometimes we just tend to say that, and sometimes we think that it's just an excuse, you know, not to do chores in school. But she now talks about rheumatism. Is it associated with sickle cell disease?
Yes. So she said rheumatism. And usually that's the layman's term for talking about the acute pain associated with sickle cell disease.
Okay.
So with sickle cell disease, what happens is that ideally you're supposed to have the blood flowing through the vessel, which is the pipe, easily. But with sickle cell disease, especially when there's low oxygen, we say deoxygenation. Okay, your blood cells, they change from the round shape to a sickled shape. And once they have that sickle shape, they tend to stick together. They stick to the blood cells. They stick to the other tiny particles that I was talking about. And they tend to occlude or block the blood, so the blood doesn't really flow. And if you have blood not flowing to any other part of the body, remember I said hemoglobin carries oxygen.
Yes.
So it means blood not flowing adequately there, oxygen is limited. Hence, is associated with a lot of pain.
Doc, it means what, the pains get better with time or with age?
So, no, not really. I wouldn't say that. Okay, it depends. There are certain factors or certain things that would help or that would let the pains come.
Okay.
Okay. One of them is cold weather, very cold weather, very warm weather. You mentioned you had mates who wear cardigans. Yes. So during the cold weather, it can happen like that. So once you take care of yourself and with good medical care, yes, the pain should reduce. And with the newer drugs that are in the system, it helps
better
with the pain. Yes.
Beautiful. Now, Priscilla, to you again. So you knew before you got pregnant because you knew since age 5, right?
Yes, please.
Let me pry a little bit. your husband, he is not
Sickle cell.
cell. Okay. So what conversations did you have?
So when I met him, I made him aware, SS, like this is my genotype, this is my history. So a lot of people left me growing up because of my condition.
As in friends?
No, like the people I meet to marry,
Okay.
or they don't want to come close to me because I had sickle cell. But when I met my husband, I made him understand. And so he read about it and find out like what he needed to know. And then he just said, okay, we could try.
He would marry you regardless.
Yes, please.
Or say to our husband. Wow. I mean, true love really does exist, because from what you're saying, people came and left, but he decided to stay.
Yeah.
Okay. And you wanted to have children?
Not really.
Okay.
Because I heard when I was a kid growing up, sickle cell and pregnancy is not that easy. There are complications. So I was very scared. When I got married, I didn't know I'll have kids, like anytime soon. But when pregnancy came, I was
Hold
scared.
on, how about him? Did he want children?
Yes, he
He
wanted,
wanted children.
Yes.
Okay. And he wanted children.
Yes.
You weren't sure whether you wanted children or
No,
not.
Not that I wasn't sure I wanted children, but I was scared of how to handle
it.
Yes.
Okay. So what did you two do about it?
So when I realized I was pregnant.
Oh, you just realized it?
Yes.
Mm.
So I started going to clinics. The thing is, my doctor told me that when you're a sickle cell, it doesn't mean you can't give birth. So I started psyching my mind towards that. But initially I was scared.
You were scared. Okay. We'll go through the pregnancy journey very shortly. But
Okay.
between Dr. Asare and Dr. Promise, I'm not sure who this is directed to. Priscilla just realized that she was pregnant. Of course, she is a married woman, and you know, she gets intimate with her partner. And then she realized that she was pregnant. Is that what you would normally advise a sickle cell patient to do? Or if you know there's something they have to do ahead of getting pregnant? I don't know which of you will take it.
Maybe both of us.
Okay.
From there. Yes. So on my aspect, which is hematology, I would say I have to counsel the patient first. She needs to know what she's going in for. Okay. That sickle cell and pregnancy, what you are at risk of having. Okay. That means probably increased admissions for pain, for transfusions, and then of course you look at the fetal aspect. Dr. Promise will talk more about that. And sometimes certain medications that the patients are on, they have to stop once they are pregnant or before they become pregnant. So pregnancy should be planned for them. So that is what I would have advised her to do.
So what we are saying is that if you know that you have sickle cell disease and God smiles on you like he smiled on Priscilla, and you find a partner who wants to be with you regardless, then you will have to start talking about pregnancy and childbirth even before you start trying with a specialist.
Yes.
Great. Thank you. Doc.
Yes.
She realized she's pregnant.
Yes. So before getting pregnant, there's an important conversation that needs to be had before.
Okay.
So the couple needs to, assuming, fair enough, she is SS and her partner is AA. But we have numerous couples there that are AS.
Okay.
Or the partner also has an S. So we need to have a meeting and then talk through the options of even how to bring about a pregnancy. Because every sickle cell disease patient adult would wish that their children do not inherit some of the S.
Okay.
Because the childhood is very stressful. The child is getting crisis, missing out on school, missing out on play, affects their socialization, affects so much. So every parent who has an S would wish the children wouldn't do that. So if the couple say they are AS, each time they conceive, there is 1 in 4 chance that the child could be SS. 2 in 4 chance that the child could be AS. 1 in 4 chances that it will be AA. Okay, and so now we have the technology to be able to take the woman's egg and the partner's sperm, fertilize, and then generate what we call embryos. And then assuming we have 10 embryos, then we analyze each of them. Oh, this one is SS, so we put them aside. This is AS. Oh, these are AA. Then we use the AA embryos to get a woman pregnant. And that's what we're able to do now, which is why it's important that for adults who are already having sickle cell, let's have this discussion and talk through these options before the pregnancy.
Okay.
And then, as much as possible, we want children born to know their genotype. Okay, because before you start falling in love, but if you knew that I am AS, then when the AS man is coming and say, no, red flag, don't come, you know, then we are selective. And that is the key thing moving forward. And so when they come now and we have discussed these and that risk is not there, we have addressed it, then we talk about what medications can she be put on to prepare her body for pregnancy.
So, but in her case, her husband is AA,
yeah,
and she is SS.
SS.
It is very unlikely that they will have SS children.
Yes, it is very
unlikely. Okay, great. So at least the children have escaped that one.
Yes,
okay,
they have.
Now, Priscilla, back to you. So you went to the hospital, you told your doctor, and then what happened? I want to know how you journeyed along the pregnancy. And also, I think that I had doctors say that, I mean, before now, some time ago, sickle cell disease patients, I mean, they stand a high chance of losing their lives during pregnancy.
Sickle cell with pregnancy was associated with about up to 5 times pregnancy complications and death in pregnancy.
Wow.
Okay, compared to a non-sickle cell person. But in low-income countries, in low-resource areas, the odds went to as high as 22 times that risk.
Like ours.
Exactly. You know, and so sickle cell in pregnancy makes the pregnancy extremely high risk. Which is why it has to be planned, and the woman, sickle cell disease patient who's pregnant, needs extreme care and then professional attention.
Great. Did you get all that? Extreme care, professional attention, monitoring, everything?
Yes, please.
Tell me a bit about it.
So I started antenatal at Kolebu when I was 8 weeks.
Okay.
Yes, so I go every 2 weeks for the antenatal. And then they tell me what to do, the medicines I have to take. And then I think every trimester, so first trimester I was anemic, I went on admission. Second trimester and then third.
All through the trimesters you were anemic?
Yes.
And were you going through pain?
Yes, but the pain series, I managed them at home.
Okay, how?
With my pain medications and my hot water.
Okay. And you had to go on admission because was the anemia that bad?
Yeah, anemic. So they gave me blood transfusions.
Regularly? For all the trimesters?
Every trimester, yes.
I see. Was that the only challenge you faced?
Yes. During the pregnancy. Then when I gave birth, I had...
Before you give birth?
Okay.
Yes. Doc, let me come back to you. Now we are pregnant. I think the two of you can, answer the questions as they come. So she was anemic. I think that's what she experienced throughout. Yeah. What else could be coming up for a sickle cell disease patient who is pregnant? But then I think we are establishing that it is not impossible for a sickle cell disease patient to be pregnant and have children, right?
Yes. Correct.
You can.
You can.
With proper care and management.
Yes.
Okay, beautiful.
Yes. So for a sickle cell disease patient who is pregnant, what we know is that there's an increased odds of having more hospitalizations or hospital visits for pain, for blood transfusion, that's because of severe anemia, And then, of course, we know there's this problem called acute chest syndrome, where they have difficulty in breathing, and that is associated with most deaths in sickle cell disease patients. And there are other obstetrics problems that they could have. One of them is that they could have hypertensive disorders in pregnancy. That's preeclampsia, eclampsia. They have an increased odds. There's recurrent infections as well that they could have. they have a high chance of having stillbirths or intrauterine fetal death,
Wow.
preterm delivery, babies who have low birth weight, okay, and then even having perinatal mortality or perinatal death once they have their child. So these are some of the problems that a sickle cell disease patient who is pregnant could have.
It's not to scare anybody.
Yes.
But does it include the mothers also losing their lives?
Yes. So as Dr. Promise said earlier, a study done in 2015, okay, they looked at both high-income settings. They are looking at well-developed settings and then the settings that are not developed, like Ghana, Nigeria, African countries. And they realized that if you look at a patient who is pregnant but doesn't have sickle cell disease compared to a patient who has sickle cell disease and pregnant, the pregnant sickle cell disease patient has a 10-fold increased odds of death or mortality.
Wow.
Okay, so that is high.
Okay, this is research you're talking about.
Yes, this is research.
Have you had those experiences personally?
Personally, yes. Okay, so in Kolebu Teaching Hospital prior to 2015,
Wow.
we realized that a lot of the pregnant women with sickle cell disease who come to the hospital were losing their lives. The maternal mortality ratio was very, very high.
Right.
So we developed a team, and that team is multidisciplinary. That means we know she has sickle cell disease and she's pregnant. So the person who is better equipped to take care of her should include the one who was taking care of her for her sickle cell disease, and then now the obstetrician because she's pregnant. And then we had other people also pulling in because we know that they could have pain, they have an increased chance of getting admitted even to the intensive care unit. So we added all of them together and then we created a multidisciplinary team. With this team, we managed to reduce the mortality by 90%. So with a good care or multidisciplinary approach to management, yes, mortality is reduced. But prior to then, yes,
it was high.
It's high.
Great. Doc, you have anything more to add?
Yeah, no, just to explain that the patient with sickle cell disease, their red blood cells break down or die off at shorter interval than a non-sickle cell disease patient. So for someone who is non-sickle cell, your red blood cells live up to about 120 days. But for the person with sickle cell disease, much shorter. So that causes the anemia. And then the body is trying to catch up. And then your anemia goes with reduced ability to fight infections. So they tend to get a lot of infections. Anemia also means you don't have enough blood reaching the baby growing inside you. So babies tend to also be smaller. And these babies, like she said, stand a higher risk of even dying in the first 28 days. Or they tend to have a higher risk of being admitted to the neonatal care because they also tend to come out a lot earlier, preterm.
40 weeks and more. The things women go through just to have a baby. You know what's interesting? Priscilla had a set of twins with all of these. We will be right back to continue the conversation. This is 40 weeks and more, and we have been talking to Priscilla, who is sharing her story with us of how, she went through pregnancy with sickle cell disease. If you're just joining us, well, you have missed a bit, but there's still more to come. So far, we have learned on the show that it is not impossible for a sickle cell disease patient to be pregnant and have a healthy child. But it comes with a lot of challenges. So this person needs a lot of care, a lot of monitoring. Preconception care is very, very important for a sickle cell disease patient because the doctors will have a lot of advice for you, do's and don'ts. It's a high-risk pregnancy we are learning about, and there's more coming your way. Thank you to Ernest Chemist Limited, to Labadi Beach Hotel, to Ship Healthcare Specialist Medical Center, also to Decozone, Dobeto Merchandise, Our Luri, and Lunch Avenue. Priscilla, You had a set of twins.
Yeah.
Congratulations.
Thank you.
Are they girls, boys? A girl and a boys.
Yeah.
Oh, wow. Congratulations to you.
Thank you.
Did you go through labor?
Yes, please.
Okay, share a bit.
Okay, so the day of my delivery, I didn't know I was in labor. So the pain started like my normal sickle cell crisis.
Okay.
So I was home and then I was in pain. So I was trying to manage it, but I couldn't.
How many weeks was this?
That was 32 weeks.
Oh, okay.
So later in the day, I called my husband to take me to the hospital. He didn't want to because I had been in and out of the hospital. So he was like, this time around, you pack your bags, you go, you are not coming back till you deliver. So when I got to the hospital, the doctor was like, why did I stay home this long before coming? I was dilating, I was already 8 cm.
Are you serious?
Yes, I didn't know I was about to give birth. So they prepared me for the labor ward, and then I went in and then I delivered.
On your own?
Yes.
Wow. Dr. Sefogah and Dr. Asare, this sounds like a miracle.
Yeah.
If she had come to the hospital earlier and you had seen signs of labor or baby trying to come, would you advise vaginal delivery?
So yeah, I mean, if she came in a lot earlier, and this was preterm labor, we initially may have tried to see if we can stop the labor.
Okay.
Sometimes we are successful, sometimes we are not.
You're not.
And so if we are not, and despite our interventions, the labor is progressing, the next question is, what's the position of the baby, especially the first one? If the first one is coming with a head, we are likely to allow her to deliver. It is if the first one is coming with the legs or the bottom or lying across, then it is not safe to allow vaginal delivery.
Okay.
Then it would have been an emergency cesarean delivery. Or if she delivered the first one and the second one's position is not favorable, we may have to go ahead and perform cesarean to deliver the second one. But when she came in at 8 cm, 32 weeks, babies were good, positions were good, let's give it a go.
So it is not uncommon for a sickle cell disease patient who is pregnant to deliver vaginally.
It is not uncommon.
It is not uncommon.
But we know that there's a slightly higher likelihood of delivering through cesarean section overall.
Dr. Asare, you look like you want to say something.
Oh, yes. I mean, Dr. Sefogah has said all that I
Okay.
wanted to say. But what I wanted to add is that basically delivering by vaginal delivery, you'd assess the mother and you assess the baby, just like what he already mentioned. Okay. And then, of course, there are certain things that you need to do when she's in labor. One of them is make sure the pain is controlled, whatever pain she has. So you give adequate pain relief. And then, of course, in our setting here, sometimes a pregnant woman goes to deliver, they say, don't drink water, don't do this. For sickle cell, we know that when they are dehydrated, they could have more pain episodes. So we hydrate them. Okay. So it means delivering in a proper setting where you can be monitored and then both mother and baby would be fine.
Okay, so it means that rushed delivery is, you won't particularly advise that.
Yeah, sometimes not under your control. But the thing is, the least unwell you feel, get to the hospital. And if it is about delivery, you know, we would wish the sickle cell disease patient delivers at least at the district level hospital, where at least there's a specialist obstetrician and there's a likelihood of having a physician specialist as well for that multidisciplinary approach to improve the outcome. Yes.
Great.
Okay.
Did you have that, Priscilla?
Yes.
Okay, everybody was there with you.
Yes.
And so tell me, babies came out, they were fine, their weight, everything?
Their weight was small. One was 1.4 and the one was 1.2.
Wow.
So they took them to the NICU.
Okay.
Yeah.
And what happened thereafter?
I went off.
Yourself too?
I went off after delivery. So when I came back.
When you say you went off, what does it mean?
You
passed
didn't
out?
know, I didn't know what happened.
Wow.
So when I came back, they told me I had post-eclampsia.
Ah.
Yeah.
What, I mean, did they tell you exactly what happened to you?
I don't really know what it is, but that's what they told me.
Okay.
And they managed it.
Did you know how long you were off for?
So I delivered in the afternoon, and then I came back. I regained consciousness in the morning.
Hey.
Yes.
afternoon till the next morning.
Yeah.
Doc,
Yes, ma'am.
that sounds scary.
It is. So sometimes the pregnant woman may have high blood pressure and start leaking protein in the urine. Then it becomes pre-eclampsia. If on top of that they develop convulsion and loss of consciousness, and that is eclampsia. Okay, and that's what she had. But sometimes the eclampsia can happen during the pregnancy, during labor, or after delivery. In her case, she had eclampsia after delivery. Sometime after the convulsion, the woman becomes unconscious for variable number of hours. Sometimes, unfortunately, we're never able to get them back.
Wow.
Sometimes they regain consciousness sooner after. So hers went for a number of hours, more than 12 hours. And then she came back, fortunately.
Fortunately. And so when you came back, you went to see your babies?
No.
Okay.
So I was taken to the ward, and then for some time they took care of me. I think I saw the babies 2 days later.
After. Were you worried about them when you weren't seeing them?
No, please. Because their father was taking care of them.
And you had to focus on yourself?
Yeah.
So apart from how were you feeling when you woke up? Were you okay?
I just thank God, because it's just God. If it wasn't God, I don't know what would have happened.
And so after how long were you asked to go home with your babies?
So we stayed there for almost 2 weeks because the babies were preterm. Yeah, so they were in incubators. So I had to go there, feed them, go back to the ward.
And you yourself, for those 2 weeks, you
myself.
didn't have any pains again, you were okay?
Okay, so for the first 3 days I was weak.
You were
So I didn't go to see the babies.
Okay.
I had to take care of myself till I was a little fit. And I went to see the babies.
But after then you had been okay?
Yes, I was fine.
Okay. And after about 3 weeks, babies were okay to go home as well?
Yeah, they were fine.
Beautiful. And then after how long did we have to go for baby number 2? This time, was it conscious?
After 2 years.
2 years?
Yes.
Did it also just happen, or you planned this one?
We planned it.
I like the sound of that. What went into the planning? Did you have conversations with your doctors ahead of getting pregnant again?
So the doctors told me after 3 years, before I can get pregnant again. So they told me to go for family planning after the twins. But when we went, my husband was like, "We'll come back. We are going to think about it. We'll come back." So we didn't go for the family planning. So after the second baby, that's when I did the family planning.
Okay. But you had you got pregnant again after 2 years?
Yes.
Okay. Doc, she has sickle cell disease. The first pregnancy was, by accident.
Yeah.
And all the issues that happened along the line, delivery,
post-delivery
eclampsia, and all of those. And then I think that she was in very good hands, the doctors that were taking care of her, because they remembered to tell her that you need to do family planning and you can only get pregnant again after 3 years.
Yeah.
She and her husband decided that they are
That's all.
And then after 2 years, did they do anything wrong? Were they putting her at risk?
I mean, so, typically for family planning, you come and we do the counseling, talk you through the options, what to expect for each method, and then preferably decide there and then which one you would opt for, and then we fix it before you go. But occasionally, very special clients like Priscilla and the husband say, "Yeah, we've heard, let's go and think about it." Sometimes you are lucky they come back that we've decided on this method.
Okay.
Sometimes, like in her case,
They never
came back. They
did
came
the
back
natural.
with another project,
Pregnancy.
And so, we would wish they space it for as wide as possible. 2 years, 3 years, that is fine. We counsel that based on every patient's situation and the woman's age as well. If you don't have a lot of age on your side, we may say even up to a year, because for us, we would wish every woman will finish having your babies before you hit 35. Every woman, sickle cell or not. That would be our ideal. So how much to space it, we will factor all that into the consideration.
Okay. Doc, you think they were stubborn, huh?
Well, I wouldn't say they were stubborn, okay, because if you look at a patient with sickle cell disease, the misconception in society is that they will die early. But that's not the situation, okay? They have an improved life expectancy with the better care. So sometimes they are pushed to try and give babies or deliver quickly.
Oh,
okay, so
before they die because of that misconception.
Yes, that's the misconception.
Oh my God, that's crude.
Yes, yes. So for them, they did the natural family planning, which is also good.
No way.
If you know what to do. I'm sure Dr. Promise would talk more about that if I'm wrong. But for us, my hematology aspect with her sickle cell disease, what I'm concerned about is she should have good care. Her HB, which is the blood level, should get to the point where it was before pregnancy. And then she should have fewer pain episodes or fewer complications. That is what I would advise. So yes, with the 2 years, I expect that all these things should
have been taken care
would
of.
have been taken care of.
Were you actually monitoring all of these to make sure that your HB was fine, you were healthy, blood pressure levels, everything was okay, because you know that you're managing a sickle cell disease?
Yes, please.
You took all of these into consideration before getting pregnant. So how was it with the second one? Was it less episodic?
Yeah, so the second one was okay.
Okay.
I didn't have a lot of anemia. I didn't have a lot of crisis. But I did CS because of the family planning. The second one was CS. So I did BTL after delivery.
Okay. But then the children are fine?
Yes.
How old are they?
5 years and 2 years.
I like it when the stories end like this, you know. 5 years. The twins are 5 years.
Yes.
And then the other one is
2
2.
years.
Congratulations to you.
Thank you.
Now, there's a very interesting aspect of this conversation that I'd like us to have, okay? I have encountered sickle cell disease patients, and as I mentioned to you earlier, the misconception, or what we have always thought about and know, is that they come with a lot of trouble. Not finding better words to use. If you are with a sickle cell patient, then we hear that even the love in the relationship will fly out of the window because of the consistent pain. You are always in hospital, you have to do this, you have to do that, and you can't even have the opportunity to enjoy your relationship. Then to think about getting pregnant on top of it and all that. Now I want to find out, can you, I mean, she found love, but would you sit here as medical officers and advise that it is okay to be in a relationship or be married to a sickle cell patient? And if it is, what precautions should people take?
So having sickle cell disease, as I said, it's not contagious, okay, and it's not a death sentence. So yes, it's okay to be married to a sickle cell disease patient. With improved care, there's good quality of life, and that's what we are all hoping that the patients would have.
Okay.
So in her case, yes, she found love, and that's what we want. Again, there should be an informed decision or an informed choice. So before you get married, you have to know that, yes, this patient has sickle cell disease, okay, and these are some of the complications they can have. I wouldn't tell you not to get married, but I would tell you what problems or what complications that you could have, and then you make the choice yourself. Once you make the choice, you are better to stick to it than being pushed into it. I would say that.
And some of those complications we have discussed already.
Yes.
Doc, could you just hammer on a few of them again for us?
Okay. So the complications that they could have, the commonest is the pain.
Okay.
The acute vaso-occlusive pain episodes that they come in with. Okay. And then, of course, their blood cells are always breaking up. So they have a chronic anemia. Okay. They can have kidney problems. They can have problems with their lungs. They can have problems with their heart. They can have problems with their gallbladder. They can have problems with their bones, especially the hip joints. So sometimes they can walk with a limp. It doesn't happen in all sickle cell disease patients, but some of them can have a lot of their complications if they don't have improved care. So
I'm sure by the time you finish breaking this down to the average man, the person will just start withdrawing, because really, the person as an individual, or, I mean, it could be the man who has sickle cell, and by the time you finish breaking, do I really want to go through all of these? And then when eventually the person gets pregnant, then it is double trouble for you. But then, of course, I know it's part of your job to educate people, and then they make the decisions. Yes, great. Doc?
Yes. So when the blood cells break down that rapidly, it's one of the reasons why they also tend to develop jaundice. Okay. So in some of the areas, they attribute jaundice to so many different other things. It's just important. Sometimes the jaundice is what makes us even detect that the woman or the patient has sickle cell disease. Now, there's a great concern of stigma, okay? And I like the question you asked. Let us establish that sickle cell disease is just like any chronic medical problem, okay? We have interventions now to deal with it. So we used to hear that sickle cell disease patients don't live beyond 40 years. That has been dealt with now, okay? So they should have a normal life. Now, one problem is from the church. Okay, church, when the young people want to marry, the church leader or the counselor will say, hey, you can't get married. No, that is not in your place to do. Let us inform, okay? Let us tell them what it is to be sickle cell AS, SC, SS, and what it is for your partner to also have this. And then they decide. And let us know that you can have an AS and AS, or AS and SC and AS versus SS come together and have children.
But
there are interventions.
Is it not coming from a good place? Before the interventions, like you have a church leader or you have your counseling committee and you approach them and they say you should go and do labs. Usually you do the labs and then you bring it. And then they realize that, okay, you are AS, and there's the likelihood that you could have an SS child who will just come and suffer. So we won't advise. Isn't it coming from a good place?
Yes, we don't say you won't advise. So inform them that this is the likelihood.
Okay.
Give them the options. I mean, the likely permutations that may play out.
I think most of the time they don't know those ones.
They don't know, and so they don't do, and so they take the shortcut. So no, we won't bless this marriage.
Yeah.
You know, they have a right. So we need to let them know. I am happy to discuss the options. Fortunately, also because we have these interventions right here, and couples are taking opportunity and using them and having their babies. Okay, and so some are happy to, and they can afford what we call the pre-implantation genetic testing, where we take the woman's egg, the sperm, form the babies, and we test them to put the sickle one out and use the non-sickle one for the woman to carry her pregnancies. Some may want to, because they cannot afford, they get pregnant, and then we test the baby inside to see what's the genotype of the baby. And based on that, we make a decision. So it depends on what each couple would accept. But the point is, there are options, okay? But moving forward, it is more important that we check the babies at birth, or as young as possible, so the growing child knows their genotype before the falling in love stage, before the church counseling stage. So they are already selective.
Informed. And they will make those decisions ahead.
Earlier, yes.
And it is not the church elders who are now coming to tell you that. I like that bit.
It's not you and the church elders.
Who and the church elders?
You and the church elders. You know, yeah.
Great. Priscilla, so you won't have another one again?
No, I'm
okay.
done.
Tell me about yourself. You work regularly?
Yes, please. So my cycle is like every quarter I break down. So every quarter I go into the clinic and then I take my medications and I'm fine.
And your employers are aware?
Yeah, they are aware.
Okay. You don't have fears? You know you've heard what I am talking about, right?
Yes.
Yeah.
I do, but I try to overcome them because I see people who are doing so well and I use them as my like I use that to motivate
With
myself.
yourself. And I want to believe that you are in very good hands. You have good care as well, right?
Yeah.
And you're taking very good care of yourself.
Yes,
Please
I do.
enjoy your life. Oh. Dr. Sefogah is there. Dr. Asare is there.
Okay.
We also have a good, lots of support systems are around. For instance, like what Nanesi and her team, does at the Sickle Cell Awareness Initiative. And so there's so much support out there, Now, before we wrap up, Doc, I will come back to find out, take your final words on caution for sickle cell disease patients, and what they really must do to increase the quality of life they live, and especially so when they plan to get pregnant and have healthy babies. But let me take this very short break, and then we will be back. This is 40 Weeks and More, and thank you very much for being our guest on the other side. We have been talking about sickle cell disease and how it plays out in pregnancy, and our guests on the show have been Priscilla, Dr. Sefogah is here, and Dr. Eugenia Vicky Asare has been with us too. A very big thank you to our sponsors. They have held us down: Ernest Chemist Limited, to Shape Healthcare Specialist Medical Center, and to Labadi Beach Hotel. And also thanks to DecoZone, the Better Merchandise, to Aruluri, and also to Lunch Avenue. I was asking before we took the break what sickle cell disease patients can do to improve their quality of life, and especially so when they are planning to get, married and pregnant. Not the by chance and the accidental ones, but when you have sickle cell disease and you deliberately want to plan for pregnancy and have very healthy babies. Improving your quality of life before all of that following.
Okay, so I should say that if you look at it, in Ghana here, 1.8% of all newborns each year are delivered with sickle cell disease.
Wow. And
15 to 30% of all newborns each year are delivered with a trait, which is AS. Okay. AS is not sickle cell disease, it is a trait.
And they say they are carriers.
Yes, they are carriers as well. So if you're looking at prevention can be in so many ways.
All
okay.
Right.
Before even you know that you have sickle cell disease, you have to be screened. Either newborn screening, or Dr. Promise mentioned when you're in the adolescent age, you'd have to be screened, or adulthood. And now pregnancy, they are screening them for sickle cell disease. And that's one way to prevent some of the complications.
All right.
Now you know you have the disease. What do you do? Okay, so you are trying to prevent yourself from having all the complications I talked about.
Okay.
Okay, so there are certain things that you know that could bring about the complications. One of them is not drinking enough water. One of them is extremes of weather. So cold weather, very hot weather can bring about some of the problems that they can have.
But you don't control the weather, so what do you do?
So you make sure when it's very cold, you cover yourself.
Okay.
You wear protective clothing. When it's very hot and everybody is sweating, don't go and wear cardigans. Try and drink lots of water. And then you dress based on how the weather is.
All right.
Okay. If you have any fever or pain, or as Dr. Promise said, if your eyes are yellow, that means jaundice. That means your blood cells are breaking up faster. Your urine can become like Coca-Cola-like.
Oh, wow.
You should go into the hospital immediately. And if you don't have any acute problem, the acute is what makes you rush to the hospital. Okay. Then you're fine. You could go in for regular checkups every 3 months, okay, to make sure that you don't develop all the other problems that could happen. Now, if you do get married, you've made an informed choice, you've met a partner, both of you have decided to have a child or not to have a child. If you decide to have a child, yes, there are certain medications that patients with sickle cell disease now are put on that improves their quality of life. One of them is hydroxyurea, which we have in this country. Okay, there are other newer drugs. If I decide to get pregnant, or if a sickle cell disease patient decides to get pregnant, some of these medications would have to be stopped. So it means that a pregnancy would have to be planned. And once that pregnancy is planned, that's preconception care, then I hand you over to Dr. Sefogah, who is the obstetrician. I'm sure he would say more on that.
Doc, we have been handed over to you.
Yes, doesn't mean you are both pregnant.
Oh. On behalf of those who are planning to get pregnant.
Very well, yeah. So like you said, we need to adjust some of the medications because some can affect the formation of the baby. Make sure you are taking adequate folic acid. As a matter of fact, anybody, even without sickle cell disease, who is intending to get pregnant, it's good to be taking 1 tablet of folic acid a day. It helps a great deal with the normal formation of the baby.
Right.
So if you're sickle cell, you need it even all the more. Then once we have talked through the options of what to do, whether you conceive naturally and we test the baby, or we do IVF to be selective of the baby, and the pregnancy has come, it requires close monitoring. Soon as you miss your period, we need to do the initial test and do the scans to make sure the pregnancy is at the right location to start with. And then the counseling in the first trimester, like you know, pregnant women have a lot of vomiting. When you're vomiting, you're losing a lot of your body fluid. You can easily get dehydrated, and that can trigger the crisis.
Wow.
So you quickly come in, we make sure we stop the vomiting, rehydrate you, keep you healthy. And then with all the other support, we would wish that sickle cell disease with pregnancy should be managed in a district hospital. If it's a private place that we have the specialist, you have the obstetrician and the physician, that is good enough. But in the bigger mainstream, at least in the district hospital, the reason is this multidisciplinary team approach that we have tried in Kolebu over the past nearly 10 years has brought the mortality among pregnant women with sickle cell disease by about 90%.
Oh, wow.
Okay, and that is because, like she said, we have the obstetrician, we have the physician, hematologist, we have intensive care anesthetist, we have midwife, we have pain specialists, all working as a team. And that does it beautifully.
That's a lot of success.
It is, yes. So she presented that results in the US recently, and we got a lot of applause.
Yeah.
You know, and so we don't have the hematologists and all the people downstream, but at least at the district hospital, you have the obstetrician at least, you have the physician, that can do.
That can
okay, and so that we can together work to optimize the pregnancy experience and outcomes for our sisters with sickle cell disease.
Great.
Let us be assured that there are options. So nobody should stop anybody with sickle cell disease from dating or marrying another person. It is not in our place.
Thank you very much. Priscilla, thank you very, very much.
You're welcome.
For agreeing to come and share your story, to give hope to others. But I'm sure you will have some final words for, you know, women who have sickle cell disease. What do you have to tell them?
I'd like to say we should attend clinics regularly, and anytime you feel sick, just go to the hospital, because that's the best place that the doctors can take care of you so that you don't lose your life.
You don't lose your life, and you don't lose your baby as well. I also want to believe that, I mean, frequenting the hospital can be quite tiring. But then, what would you rather do? Stay at home, crisis, and then it becomes something else? Or you'd rather go to the hospital where you can have that quality care? So it's important that we do. Dr. Asare, Dr. Sefogah, and Priscilla, thank you once again for coming. This has been school for some of us, and I'm sure for a lot of people who are at home. It's not a contagious disease, so there's no point stigmatizing. Rather, we should be empathetic, as I always say on the show. My name is Edem Knight-Tay. Thank you to Ernest Chemist Limited, to Shape Healthcare Specialist Medical Center, to Labadi Beach Hotel, also to Deco Zone, Aruluri, to the Better Merchandise and Lunch Avenue for bringing us 40 weeks and more. See you. Bye.